patients. So we move on to the next talk, since we are short of time. The next talk is on surgical failures. So the patients who are treated medically and they fail with the maximal medical therapy are taken for the surgical therapy, yet surgery is full of risk. And the biggest risk is the risk of failure of the surgery. So to talk on this topic, may I invite Dr. Kumar Ravi. Please share your screen, Dr. Kumar Ravi. Dr. Kumar Ravi is a proficient and a very renowned glaucoma surgeon from Kolkata, eastern part of India. He's a postgraduate from Minto RIO, Bangalore. He is an ex-consultant of Sankar Netrala. After doing his post-graduation, he has done glaucoma fellowship and a comprehensive fellowship from LVPI. He is an ex-consultant of the Sankar Netralaya and now associated with Netralium. He is Masters in Ophthalmology from RIU and is actively involved in the training of undergraduate, postgraduates, as well as a various ARC program to teach the common or the general ophthalmologist or the people who are interested in glaucoma to various procedures of glaucoma. May I invite Dr. Kumar Ravi to deliver his talk on glaucoma surgical failures. Think ahead.
I would like to thank you.
This is not clear, Dr. Ravi.
Am I audible now?
Yeah, please go ahead.
Okay, so thank you for having me in this talk, and let's start with the presentation. Surgical failures. Think ahead. Normally, when we think about the glaucoma surgeries, the doubts.
1 minute. May I request other participant on this forum to mute themselves? Please go ahead.
Okay, so normally when we start thinking about glaucoma surgery, the things that comes to our mind is which site we should do, what should be the size of our incision, what should be the size of stoma, should we use mitomycin, which surgery is good. But over a period of time, I have realized that these things do have their own importance, but what we should focus on once we have decided the surgery, what exactly we're doing, how beautifully we can do the surgery so that the failures can be minimized. In first part of my presentation, I will be sharing some of my experiences with some of the cases in which I had difficulty, and I have formulated some guidelines for myself, which I will be sharing with you all. So how to avoid failures in TRAB? First thing to note is we have to be very careful in the care of conjunctiva and cornea. And we have to cut and cut very precisely with predetermined size. And we should be using cycloplegics at appropriate time and should avoid chamber shallowing at all cost. Now, if we see the TRAB surgery, the most important step to begin with would be that the surgery should be done in a precise manner and conjunctiva should be cut in a straight single incision so that the conjunctiva should be straight and not ragged. If we see this particular photograph, at the end of the surgery, the conjunctiva should be covering 1.5 millimeters of the superior limbus or cornea, clear cornea. See this example here, the surgery was done, but somehow the conjunctiva on the day of surgery or day 1 post-op has receded back. And let's see what happens if it recedes back. So in these cases, day 1, this is a situation, day 7, conjunctiva goes further back, and this area is not covered with conjunctiva, it heals with epithelialization. If that is a scene, there are high chances of failure. On the reverse, the second case which has shown, if your conjunctiva is covering the limbus very well, in future you will have a nice, good bleb, and the likelihood of surgery being successful is higher. Another important thing, again, in relation to conjunctiva is we should avoid buttonhole. Nowadays, because of excessive use of anti-glaucoma medications, before we take a patient for surgery, the conjunctiva is very thin. And in case there is a buttonhole or if the conjunctiva is ragged, then there are high chances of complications. In this patient, since there was a buttonhole, aqueous was leaking out through this. Not only the surgery ultimately failed, it gave much trouble in the form of choroidal CD, choroidal detachment. Now, another important step is application of mitomycin if we decide to use it. So when we apply, we should be very careful that it should be only at this required site, it should be applied or underneath the conjunctiva. The margin of the conjunctiva and the cornea or the structures in the anterior segment should not get exposed to this agent. See what has happened when the mitomycin is like cornea gets exposed to mitomycin, almost near total epithelial defect. And in this case, somehow the surgeon had decided to apply mitomycin after entry to the AC, and little bit of mitomycin probably entered the anterior chamber, and it's a complete different story altogether. Now, if it is applied in excess, within days to weeks, we can have complications like this. So we should plan beforehand what strength and for what duration we are going to apply in antimetabolites if we decide to do so. Because even months to years later, we can have overhanging blebs and complications related to the same. Though initially it may give us success, but later it gives us a lot of trouble. So we should be like sure how much application has to be done. Now coming to this case, like I would just like to show that when we are planning to take an incision here, the most important thing is that the field should be very clear. No bleeders on the conjunctiva, scleral surface, or when we make the stoma, there should be no bleeders towards the stomal edges or towards the ciliary body. Otherwise, on the next day post-op, if we have complication like this, there are, see, you can see the streaks of blood is probably coming from the surgical side, and this will cause scarring of the bleb area and may give us a lot of trouble. If we have more than half chamber hyphema, then probably it will require wash also, and there are always chances of rebleeding also. So again, it is the beginning of a new story and complications. So we should avoid bleeders at all cost. Coming to third most important complication, we should not have shallow AC when we are closing the surgery. Many surgeons are of the opinion while operating that, okay, even if it is a little shallow, let's close it, next morning it will be okay. It's never so. Whatever we leave during surgery, next morning also it's either shallow, or sometimes we will have total AC shallowing, and then it takes a lot of effort and time, sometimes resurgery, reformation of AC is required. So my suggestion would be, if you see that there is AC shallowing, see here the people who was trying to come towards the surgical side, that means the AC shallowing was there. So I decided to take as a releasable suture immediately. If it is a good idea to learn releasable suture, if not, we can give an extra suture here and make sure that's the AC is not shallow at the end of the surgery. Now, in post-op period, if we see that the surgical site, there's a good bleb, but there are corkscrew vessels, we should plan to give antimetabolite injections like 5-fluorouracil or mitomycin C, because this kind of bleb, in few days to weeks, it will get converted into totally fibrosed area and our surgery will fail. So corkscrew vessels, sign of danger. So not to forget, conjunctiva should be cut carefully, watertight closure, sclera, there should be no bleeders, and A-shoot should be well formed at the end of surgery, and metabolites should be used with caution. Coming to part 2 of my presentation, this is with relation to the Emmett glaucoma valve. Now, let's see this video. When we are doing the surgery, we should be careful that the valve of Emmett glaucoma valve should be at least 8 millimeters away from the limbus. If not, if the valve is little closer to the limbus, there are always a chance that because of rubbing with the lid, there can be exposure of the valve later. Many times this surgery is done in complicated eyes or in post-VR surgery eyes, and there are always a chances of exposure. If you see here, there is tube exposure because the surgeon probably has not used cover in the form of donor sclera or donor cornea. So it's always a good idea to place this valve at least 8 millimeters away and to cover this tube with a scleral patch graft or with a donor corneal patch graft. Otherwise, sometimes we can have major complications like this. This was a pediatric case. I had refused surgery in this patient, but he got operated somewhere else. And one midnight, he came with this kind of complications, total valve exposure. Now, like how meticulous we should be during our surgery, I would like to highlight with this case. Have a look at this particular area. If you see carefully, you will see that the Emmett glaucoma valve tube, which should be in the anterior chamber, has gone behind the bag. It is in fact behind the PC. That means it is behind the bag because lens is in the bag. So if it is behind the PC, the vitreous chamber can be expected to work. So there should be a careful placement of tube in the anterior chamber, and it should be cut to the appropriate size. See this post PK patient and this kind of large tubes. I can understand the urgency of surgery, but this kind of long tubes will ultimately cause the graft to fail. And here, this required, in fact, required resurgery to place another MR glaucoma valve to control the pressure. The pressure was 36 before surgery, and after surgery also, it was 36. It was done in a neighboring country, Bangladeshi patient. It was done in Bangladesh, but it's an interesting case. It has gone into the pars plana, in fact, in the vitreous cavity. Another interesting case I would like to share with you. This patient had 2 failed traps, was aphakic, status post vitrectomy. My colleague did AGV surgery in this patient, and see, next morning the vitreous strands are going into the tube. In glaucoma surgeries, we don't have to do things improperly. Like, even if you do all things properly, complications come unasked for. So this is a vitrectomized eye. We are not expecting any vitreous, but next morning the vitreous is going to the tube, blocking it completely. And then we had to go and clear the vitreous, and then finally the tube, the surgery was successful. So our understanding with this case was that we should follow standard protocols and should be ready for surprises, and then with the means to handle it. So we have to do glaucoma surgery very meticulously, still be ready to handle complications. I thank my team for their guidance and help. Thank you.
Thank you, Dr. Kumar Ravi, for your wonderful talk. Just one question. We know that we have to give a lot of respect to the conjunctiva. Now, coming to the flap management, do you use releasable sutures? If yes, then how many releasable sutures, and how do you proceed for release of these sutures during the post-operative period to maintain the intraocular pressure of the patient?
Okay, in my practice, most of my patients are those who are already on multiple medications for years together, and they have very thin conjunctiva. As I have explained in my presentation also, that I have been seeing a lot of complications because of use of antimetabolites. So nowadays I've reduced the use of antimetabolites, and I focus more on using surgical techniques, precise surgical technique to get a good bleb. And the releasable suture has become a part and parcel of my practice. There's hardly any patient in which I don't use a releasable. In many patients, and especially in the complicated cases like, say, high myopic eyes and all, I used 1 to 2 releasable sutures. 1 is almost in all cases, sometimes 2 also. As far as the release of these sutures are concerned, normally my pattern is first suture I release on 3rd day, and second would be around 7th day. But then again, it depends upon the condition. The main idea is AC should not be shallow. If you see that the AC is becoming shallow on table, go for a releasable. Or if you're not used to releasable, put 1 extra suture. Because if AC is shallow, next morning you will have AC shallowing, and then in coming days you will have iris adhesion with the cornea, synechia formation, and other complications. So if we are using, say, suppose if we're using mitomycin, then the releasable sutures can be released even little later, say up to 2 weeks also we can go ahead. But if you're not using mitomycin, I try to release 1 suture within a week, and second suture would be roughly around, say, 7 days to 10 days time. And after that, if we give a gentle massage, the bleb forms very well. And if the eyes hold, or if your eye shows a good bleb around 7 to 10 days time, we can be sure that the surgery should succeed.
Yeah, thank you, Dr. Kumar Ravi. And in fact, it is very important that a shallow AC should be maintained, managed very carefully in the post-operative period. If we see a shallow AC on table, or in the first post-operative day or a second post-operative day, these are the patients who need to be kept for a long follow-up, and we need to be very particular in managing these patients, else we will land up into